Welcome back to another episode of Preserve Health Talks. I'm Dr. Ira Perlstein, your host, and we have with us today, again, Lois Castle, APRN, with Elite Health and Wellness Center here in Port St. Lucie, and she is now our resident women's health and hormone expert. Good morning.
Good morning.
How are you?
How are you?
Good. It's been a while since we've done a women's health-focused episode, and today I thought we'd talk about menopause, which is one of those topics that affects every woman. Yet many women still feel underprepared when it starts and they don't know quite how to deal with it. And we've all heard the phrase going through the change, but that can mean many different things to many different people. Hot flashes, night sweats, sleep disruption, mood changes, weight changes, brain fog, vaginal dryness, urinary symptoms, and sometimes the complaint I get, I just don't feel like I used to.
Exactly.
Can you bring me back to that? I know you can do that. I want to talk to you about how you do that and help our viewers understand what's happening to their bodies during menopause, what's normal, what's not normal, and what options women have to feel better and protect their long-term health and sense of well-being. So, my opening question to you, Lois, is every woman's heard the phrase going through the change, but many women are surprised by how many body systems are affected. When a woman says, I don't feel like myself, what's actually happening hormonally and physically to them?
So there's two stages that women go through when as they're aging. So there's perimenopause and menopause. Perimenopause is the period that leads up to menopause, and that can start as early as late 30s to early 40s, and it can last for several months. It can last for 15 years. It's all very individualized to the woman. And what happens during this time is we start to see fluctuations in estrogen levels and progesterone levels, and testosterone levels are usually the first that start to drop off. As they move into what we call menopause, menopause is basically there's a no period for 12 months, and the ovaries cease to function, and they stop making estrogen and they stop making progesterone.
Are there exogenous, other than the ovaries, places in the body that produce estrogen? Because some people have almost like a double menopause. They go through the change, they're fine, and then several years later, in their 60s or even early 70s, they start having hot flashes again. What's happening?
So I've heard this second menopause expression. There is no real such thing as second menopause. When you go into menopause, you're in menopause for the rest of your life. There are certain factors, though, that can bring back symptoms that might have once resolved, and though that would be more lifestyle, disease processes, certain medications, lack of exercise. There's different things that can cause that, but they should never, those symptoms in the 60s and 70s that come back should never just be assumed to be menopause. They need to be worked up and make sure that there's not something else going on also.
So, when I went through my training, which was several decades ago, and the barometers kind of shifted. Hormones, no hormones. Hormones are good, hormones are bad. Women's health study, it was bad. No, it's really good. The absolute numbers weren't as high as we once thought they were. Hormones are generally safe. Keeping all that in mind, why do some women seem to sail through menopause while others continue to have severe hot flashes, night sweats, insomnia, and mood changes, despite being on hormones?
So, well, that just points to the individuality of women. Everybody's body is different. Everybody's state of health is different. Everybody's metabolism is different. So some women get drenching hot sweats and night sweats, and some women don't have that at all. It's just their state of health, their activity levels, all these things play into how they respond to these hormonal changes.
So not to be too tangential, I want to get back to the hormones for life or no hormones at all. Women, younger women can start off on the birth control pill, stop it when they are ready to have their families, resume it afterwards, and then when menopause hits, they go on hormone replacement therapy. Safe? Not safe? Let's talk about who should not be on hormone replacement therapy.
So women who most women should be, okay, but there are certain contraindications to that. Women with certain cancers should not be on hormone replacement therapy. Back to the birth control pills that the younger women are taking, those are synthetic hormones, and they come with way more risk than the bioidentical hormones that are used in hormone replacement today. So women with a history of blood clots, you would be more conservative with, or that's really it. Cancer and blood clots.
And migraine headaches with aura.
Well,
What about that?
Some patients with migraine headaches, their symptoms improve with estrogen. Premenstrual migraines, for instance, are caused by low levels of estrogen. A lot of menopausal women also get migraines that are very similar to premenstrual migraines because they're caused by the same root cause, which is low estrogen or no estrogen. So sometimes the hormone replacement helps the headaches quite a bit in the patients that I see in my observational life.
So generally, if they have migraines with aura, though, where you're having visual changes or even visual loss, it's been reported that estrogen can make that a lot worse. I usually run that by a neurologist or an ophthalmologist, make sure that they don't think they would have an incidence of complete vasospasm with that aura, where you tend to lose your vision or have an abnormal sensation before you get your migraine prior to doing that. I've always thought that's a little bit safer. Are you aware that the literature might have changed on that since we are now using more bioidentical hormones than synthetic hormones for hormone replacement?
I believe that the bioidentical hormones don't cause any more significant risk to a patient in any area than their own body's natural hormones would have caused them. There's controversy also about seizure patients. So the old literature said that estrogen lowers the seizure threshold, which means more estrogen makes you have more seizures. There's also now literature, and I have a neurologist here in this community that actually refers seizure patients to me for estradiol treatment, and they have less seizures. So the literature is very mixed on both of those topics.
Okay. So for our viewers, hormones, bioidentical hormones, what's the difference? What is a bioidentical hormone as opposed to the old Perimenopause?
So a bioidentical hormone is molecularly identical to your body's own hormones. So your body perceives it as its own. Whereas with a synthetic hormone, it is foreign to your body and has more risk of side effects.
So as we're talking about this and talking about hormonal therapy, who's considered a good candidate, or are all women going through menopause then candidates, except for those few contraindications we talked about for hormone replacement therapy?
Yes, all women need estrogen unless it is contraindicated. There are over 400 documented reasons why women need estrogen. women who are symptomatic certainly should get help. Whether they are in full menopause or perimenopause, we can still treat them.
How much and for how long?
Forever. I intend to continue my hormone treatments as long as I can find somebody that will give it to me. There's no reason. Menopause is going to happen to every single woman, but they don't have to suffer through it. Some women do stop their treatments after so many years, but it is not necessary. Whereas back when we were only doing synthetic hormones, 5 years was the cutoff for hormone treatments. But that was pretty horrible for women because they had been comfortable for 5 years and then had to suffer with the symptoms of menopause for the rest of their lives.
So now we've got women on hormones indefinitely. A complaint I hear in my office is, does that mean I still have to have a pap smear? Does that mean I still have to have a mammogram because I thought I could stop my mammograms when I got older? Now I'm on hormone replacement therapy. What's your take on that?
They have to continue to do all cancer screenings. And I believe that women, whether they're on hormones or not, should continue to screen for cancer because we are living longer. And if you're going to live into your 90s, I think it still matters in your 80s whether or not you're going to have cancer.
Okay. So one rule of thumb that I've always used is if you have a pretty good quality of life and your chance of survival is 10 years or more, then you should continue cancer screenings.
Okay.
So that's just the rule of thumb that I use with my patients and put out there. Seems to work well.
Okay.
All right, so now we've established women need hormones. Women need bioidentical hormones. It will help them go through menopause, help them feel better about themselves. 400 indications. We know that hormone therapy builds bone. It causes less dementia. It is protective against cardiovascular disease.
Correct.
Just a whole number of...
Even breast cancer.
Yeah, even breast cancer
Yes.
for some types.
Yes.
Yes. I mean, obviously not if you're estrogen receptor positive.
Correct.
And you've got an estrogen, on board, which feeds into that cancer.
But if you don't have a cancer, it is protective.
It is protective.
And we find that outcomes are better if they develop breast cancer, even as long as it's stopped, if it is.
Right. And here's a rule of thumb, folks, that hormones do not cause cancer. If you have a cancer, it can feed into that cancer and make that cancer worse. But hormones in and of themselves don't cause cancer. So now that we know that you've established the fact that women need hormone therapy, how do you give it? Pills, patches, gels, creams, rings, pellets, all of the above? And how do you decide what you want to use?
Yes.
Okay.
Okay. These are all the ways. There's even injectable for women. But certain deliveries, and even in the whole bioidentical realm. So there's oral estradiol that is bioidentical, but is not as safe as topical estradiol or progesterone. Nope, not progesterone. Progesterone oral is very, very safe. But there are different deliveries and different safety factors, and what woman gets which delivery system is very individualized to their lifestyles, their comorbidities, their overall general health, that we determine that in the consultation.
And we always see a subset of patients that I don't want hormones. I don't like having the symptoms, but for one reason or another, and there are a number of reasons women don't want to do things, and you want to please your patient and give them the best care, but still keep within the realm of doing what's correct for the patient. Let's talk briefly about non-hormonal treatments for menopause.
So all non-hormonal treatments for menopause will treat a symptom of menopause. For instance,
Hot flashes are often treated with antidepressants. Night sweats are sometimes treated with gabapentin. Weight gain is treated with GLP-1s. All these things have a certain amount of efficacy, but they don't treat the underlying problem. The underlying problem is a lack of hormones. So the real way to treat a lack of hormones is to give the patient the hormones back, and then the symptoms go away. But the literature says that the non-hormonal methods are 40 to 60% effective. I don't see that in practice, but again, they're treating a symptom rather than the problem.
Gotcha. All right. So, if a woman listening to our show today is in her late 40s, 50s, 60s, or even older, and feels dismissed by her physician with, it's just menopause, don't worry about it, everybody goes through it. What should she ask her clinician without changing her clinician? What should she ask her clinician, her physician, or whoever's taking care of her about hormone therapy to convince that provider that hormones should be used, and what symptoms should never be ignored by that physician or clinician?
I feel that if symptoms are affecting the quality of life of a woman, if they are having drenching hot sweats where their husbands can't even sleep with them sometimes, I don't feel that any of that should be dismissed ever. It's a tough uphill battle to convince certain clinicians and providers that hormones are right for a patient. So it's tough. I have a lot of women that are very dismissed by their providers, and when they come to me, they feel heard. And that's really important. I think that's a shift that the providers need to make more than on the back of the patient to try to prove that they need something.
Okay. One line, takeaway message. What do you want our audience to know about menopause?
So menopause is a normal part of life, but it doesn't have to be suffered through. And that we do have evidence-based ways to make the quality of life better for women, and every woman should feel heard and should have a right to choose the therapy that's right for her.
You know, Lois, this has been incredibly helpful. I think the key message is that menopause is common, but women don't have to suffer through it.
Exactly.
We've got things out there, meds out there, hormones out there that can help with sleep, with mood, with intimacy, with increasing energy, which ultimately will increase the quality of life. So there are hormonal options. There are FDA-approved bioidentical options. There are non-hormonal options. And there are important lifestyle and long-term health considerations, which we didn't even get to, diet and exercise,
Exactly.
but we're out of time. So the right approach then depends on the individual,
Yes.
what you as the patient wants, and what we as your healthcare provider, your doctor, your APRN, feel is right for you. So thank you again for helping make this topic understandable for the audience, making it practical and less intimidating for our listeners. We'll have you back, and this has been another episode of Preserve Health Talks. We'll see you next time. Thank you.